So, okay, perfect. And again, thank you for being with us, Joe. I don't know if I can do you justice by introducing you, Joe, but I'll let you tell us about yourself. Thank you for coming. My apologies for being dressed up like this, but it's still 5 p.m., still early for me. I'm supposed to be at work.
Sorry about that.
No, it's all good. We're really happy to learn from you. And the purpose of this is to spark discussion about and awareness about DCS in lieu of just cases that happen mostly in scuba, but in freediving as well. And barotrauma, which I am currently a patient of barotrauma.
Yeah.
And
certainly a thing.
Please go ahead, Joe. You're welcome, and thank you so much. It's invaluable. Go ahead.
Oh, thanks, Doc. I appreciate it. Good seeing you guys. Thank you guys for your time and effort and information here. I go through a little bias slide every time I do a lecture, just so that you, if we're doing this for CMEs, you know where the money comes from. I'm a former and retired special operations officer. That is me in uniform about 1 million years ago. I derive income from that. I sit on the special committee for the American Bureau of Shipping for building undersea vehicles and hyperbaric systems. I don't receive income from that. I'm a one atmosphere suit pilot. That's my first ride in the one atmosphere suit. That goes to 2,000 feet. I'm on the board of directors for the International Board of Undersea Medicine. I derive income from that. Mainly that's from teaching hyperbaric medicine courses. I'm on the board of advisors for IENTD. That's a technical diver training organization. There's no income from that. I'm a PhD in biomedical engineering, and I'm a professor of, I'm an assistant professor of medicine at Morsani Medical College, and I'm an assistant professor of biomedical engineering at the University of South Florida. So I teach a little is what that comes from, and I basically derive income from that. I'm looking at doing this Poseidon 100-day undersea mission. The current world record for living underwater is 73 days. We intend to break that record wide open this year by going over 100 days and doing physiological experiments. So basically my life is just a fun meter pegged way over in the red. But that at least gives you a little bit about my bias and my background and where I came from and what my knowledge is of this particular subject. So before we get into the signs and symptoms, I said this is kind of a review, right? And that maybe is a review. Some people know this, other people really don't. But in about 1840, caisson workers were starting to have some real serious issues. Caissons are these little boxes that they put underwater that they fill with air. And when they're fixed to the bottom, then the sand hogs would go down there and dig out all the sand until the box settled into the bedrock. And when the box settled in the bedrock, they'd take everybody out, they'd fill that box with cement, and that would become the bridge abutment, right? That'd be the whole bridge foundation, if you will. But they had to hit bedrock because you can't pour concrete on sand, so that wouldn't work. So they started having some real issues in the 1800s. The Brooklyn Bridge was constructed, and we knew that when people came out, they would bend over in pain. So when you stooped in pain, this was the ideology of the term, the bends. Incidentally, Washington Roebling was the chief engineer on the Brooklyn Bridge, and he was saying, hey, these sand hogs, they're just faking it. They're malingering, right? so he's like, I'm going to go down there and see what's going on. So he goes down and then comes back up after a little bit. He came back up and he was paralyzed from the waist down, and consequently he finished out the rest of his days overlooking the project from a hotel room. But he was paralyzed, and we didn't have a way of dealing with it at that point. Now we do, but. Paul Burt, called it caisson's disease in the 1800s and figured it was about the nitrogen loading or the inert gas loading. So the bottom line that we think DCS comes from, the precipitating event, is the formation of that inert gas bubble, okay? That's Henry's law. Henry's law has to do with absorption, and the absorption of that inert gas, you can increase it depending on the amount of depth you go to. Think about solubility of that gas If you heat something up, it's going to become more soluble, right? If you increase the pressure, things will solute into it more. So the problem is that DCS presents itself in so many different ways. So what we wound up doing is we wound up looking at this from a clinical perspective, right? From a perspective of here's DCS, here's how we see it, here's what we see happening. So with that, one thing that I wanted to go over was something called pulmonary overinflation syndromes or extra alveolar air. You guys should not have problems with this, but it's more common than you would think. And we've seen like a 30% increase in mediastinal emphysema and subcutaneous emphysema since COVID. So it's post-COVID lung, we've seen, I'm serious, a 30% increase in mediastinal and subcutaneous emphysemas. So when I get to the end and we start talking about diving in COVID, that's a real thing here. But these pulmonary overinflation syndromes are just a popped alveoli, right? So you go bronchial, brachioli, all the way down to the alveoli, and those little sacs expand and contract when you breathe in and breathe out, right? So those things are great, except they don't hold pressure well. The shallowest recorded depth of in this case, an arterial gas embolism or pulmonary overinflation syndrome is 1.5 pounds per square inch. That's the shallowest recorded depth differential. That's 3 feet. So realistically, you could hold your breath from 3 feet to the surface and get a pulmonary overinflation syndrome or extra alveolar air. So it's one of those things, like it's kind of sort of known, but not really. Pneumothorax and tension pneumothorax are just gas trapped in different spaces, and expanding that gas is the tension. The arterial gas embolism is that alveoli popping and then it returning through the arterial system and then going up from the heart being pumped directly to the brain. So, that's a really bad sign. All right. So here's the problem with DCS. We see DCS and we see DCS type 1 and DCS type 2. We're not even going to go over that because I don't want you guys to memorize that in any way, shape, or form. What I want you to do is look at this system that we have, this new system that we've developed. It talks about tempo, it talks about progression of the disease, and it is relevant and relative to the seriousness. Like type 1 is less than, tier 1 is less than tier 2 is less than tier 3. So we've broken them down, and basically none of these tiers really truly matter because we only treat the symptom. But hopefully it'll give you a way to start thinking about DCS differently. So let me put a disclaimer out here. If you ask the layperson on the street what causes decompression sickness, they go, I don't know, I think it has something to do with bubbles. Then you ask maybe a dive master or something, and they'll tell you, oh, it has to do with shaking up the soda bottle too quickly and opening it up, and those bubbles coming out of solution. And that's a reasonable explanation of it. And then you talk to like a medical doctor who's been through a course that's really good, and they'll talk about, the phagocytes and the leukocytes and your body's immune response, the bubble coming out of solution, the endothelium lining stripping away, the basement membrane leaking and vasoconstriction and all that other theoretical garbage, right? And then you talk to the 6 people in the world that know decompression sickness, and you go, hey, what causes decompression sickness? And they say, I don't know. I think it has something to do with bubbles. So the bubble thing is really, it's a theory. We think we know what causes DCS, but we're not sure. We obviously know that Boyle's law has something to do with it. It's a great deal. As you increase the pressure, you are obviously compressing that space. That means it can hold more dots of inert gas in this case, right? So you're able to absorb at 2 atmospheres, you're able to absorb twice as much, 3 atmospheres, 3 times as much, 4 times as much. So that compression thing is continually happening. This is also the reason for the pulmonary overinflation syndrome. That's because you overexpand that alveoli. When this lets off the pressure, that it has to expand again. So All right, so when we model decompression, we model it like this. We model the body in this case, 16 compartment algorithms. We have done it in many less. We started with, I think, a 7 compartment algorithm, then we went to 10, then we were at 12, and then 14, and now we're at 16. So what we say by modeling is we go, these tissues are uptaking the inert gas slowly. And that is, so for instance, bone. Bone is a tissue that uptakes inert gas very slowly. Adipose tissue or fat, yet another one. It's poorly perfused area, so it takes up gas very slowly. So when we look at the modeling, we call the compartments by their half-life or their half-time full. And we do like a standard radioactive half-life of 6 half-lives, and it's considered full. So for instance, if you have a 5-minute tissue compartment, like let's just say blood. Blood is a very fast tissue. Blood is almost immediate. So let's say it's a 5-minute tissue group. After 5 minutes, it's half full. Remember I said you can go to 2 atmospheres, you can get twice as many inert gas dots in there. But yeah, after a period of time, right, you have to saturate. That gas has to come in. So it's a slow process. So after 5 minutes, that compartment is half full. After 5 minutes again, it's half full again. As you can see, it's going right up here. And then again, it's half full again, 5 minutes, 5 minutes, 5 minutes, 5 minutes. So what that says is that a 5-minute tissue compartment takes 30 minutes to fill up, right? I mean, that's a long time. With respect to free diving, that's a really long time. I don't think you guys have 30-minute breath holds. Maybe you do, I don't know. But the interesting thing is that the desaturation is nonlinear, just as the saturation is nonlinear. So, and this problem has a lot to do with our body's immune response. I mentioned those things called phagocytes and leukocytes, and they are pictured right here. So here's the inert gas bubble in picture 1, frame 1 on the left. You see right in the center, the inert gas bubble. The phagocytes and the leukocytes are glomping onto them and they're checking them out. And they say, hey, I don't like this thing, whatever this thing is. I don't like this thing, it's a foreign body. Then they go, all right, we're gonna send these things called macrophage out there to eat it, or basically envelop it. So the macrophage come out there and they try to eat it. And, you know, then the fat globules and anything else that's, you know, those particles that are in your bloodstream kind of glomp onto this thing, right? And then if you go to picture 2, they form basically this big conglomerate, right? And if you go through, if you take a class in fluid dynamics, you'll know that on a turn, as you're turning in this blood vessel right here, on that turn, it's the blood flow is moving slower on the inside because it's shorter. It's a shorter distance. Has to move faster on the outside. So that gives anything that's in the bloodstream this propensity to raise up towards the top of it, right? So here it is raising up towards the top of it, as you can see in picture 3. And then what it does is it strikes off the inside of the endothelium lining, right? This is the inside of your vein or artery, right? Once you go off that, you whisk away the endothelium lining and you cause the basement membrane underneath that to start to weep or leak. And when you do that, the consequence is vasoconstriction. So your body's natural response is to get smaller, right? So the vein or artery gets smaller. And as you can see in picture 4, that was only one bubble. That was only one bubble in the destructive path, right? So that bubble is now gone. There is no, you're not worried about that bubble. It's gone and going out. And if it's in the venous system, it's probably on its way out, and the venous system gets bigger as it goes anyway. So it should not be a problem. But now you have this vasoconstriction down here in the 4th picture. That vasoconstriction, that closes that artery or vein in this case, that closes that vein in this case. And what you have is hypoxia on the other side. So the problem with decompression sickness is the ischemia, the swelling, the inflammation, and your immune system response. So that's the difficult part behind it. So what we did was we broke these things up into tiers of symptoms. And what we found is that every single person that we have come across has had these common core symptoms as a first symptom. So what does that mean to you? Here's the part where I go, pay attention, pay attention, pay attention, right? So if you have post-dive, if you have lethargy, nausea, or a headache, these are cause for concern. So you should be concerned about them. Now, they're not diagnostic of decompression sickness, but we know that every single person that has had decompression sickness started out feeling like this when they got out of the water. Now, let's agree, you could be lethargic because, God, you had to wake up at 5 o'clock in the morning to, drive down to the competition. You could be lethargic because you didn't get a good night's sleep because you're all amped up. You could be nauseous because you're on the boat and the boat's rocking around, right? You could have a headache because, I don't know, somebody's yelling at you. Whatever. There's all kinds of possibilities here. So they're not diagnostic. They're non-specific symptoms, but they are definitely tier 1 symptoms. So what I want you to do is, if you have lethargy, nausea, or a headache, increase your hydration and start to take note. That's it. At this point, you shouldn't do anything. You're not bent. You don't have DCS, but you may be thinking about it in the future, okay? So the next thing that we see is tier 2 symptoms. These are definitely diagnostic to decompression sickness for sure. Lymphatic obstruction, so you have lymph nodes all over your body, here, underneath the arms, in the groin, okay? So those may swell up. You may have lymphedema or swelling in an extremity. So like your entire arm may get really puffy, but this arm will be fine. So your left arm's okay, but your right arm's not okay. Musculoskeletal pain. This is the hallmark of decompression sickness. This is like no kidding, most of the people get pain from DCS, right? So this pain, it is not specific. So I know you can't see very well, but if I can point right here on my elbow and I say, there's my pain, it's right there on my elbow, that's probably not decompression sickness. Somebody describes decompression sickness pain as being inside the joint. Like they'll just be like, it's in here, it's inside. I can't really tell you exactly where it is. So generally speaking, it's boring, it's dull, it's kind of like, oh, God, and then it may or may not get worse. It may have a tempo to it. So you may have a little bit of musculoskeletal pain to start with. On a scale of 1 to 10, it's a 2, and then it may get much worse over time. So that would definitely be a true indicator. Some of the worst decompression sickness is if you have it in the hip or the girdle area. Girdle decompression sickness is a very bad actor. That's something that you really want to be concerned about. So the other thing is a rash. If you've ever seen a good steak, it's mottled or marbled. That would be something that your skin would look like. It may or may not, for the docs in the audience, it may or may not have pitting edema. It may have a little bit of swelling that you can push your finger into, excuse me, that you can push your finger into and it may not come back, but it's bluish, blotchy, reddish. It may be like, it may be orange peel looking. It may have a rough texture, but like it said, it looks like a mottled piece of steak. And, interestingly enough, where we find this is in the fat, in the areas where you store fat. So generally speaking, for the males, it's in the stomach, the abdomen, and the chest and back area. And for the women, it's in the breast and the hips. So that's where we wind up seeing it the most. So they used to call it the fat bends, cutis marmorata, or this rash that we're talking about. They used to call it the fat bends. So. And then subjective sensory changes, just you feel a little funny and you don't know how to, altered sensation in your skin. So all those are tier 2, right? So those are basically walk, but do not run to the decompression chamber, right? Because it's not like you're not falling over, So, and then these are tier 3 symptoms, and these are pretty straightforward. And I will tell you this is a run to the decompression chamber. Because you have had tier 1 Now you've had tier 2. Now you're getting tier 3. These are problems. Changes in consciousness or obvious confusion, difficulty with speech, inability to talk, walking or balance disturbance, and that has to be differentially diagnosed with an inner ear barotrauma, because if you have inner ear barotrauma, you're going to have the staggers and an inability to walk or a balance disturbance. Your vestibular process is going to be all messed up. So if you have sensory loss, that's obvious to both the diver and an examiner. Weakness or paralysis. So we're talking high level weakness. So if you're doing your arms up, you won't be able to lift your arm against gravity. These are the most serious ones. There might be some minor weakness, the difference between a grade 4 and a grade 5, but that's more like a tier 2 and less like a tier 3. But these tier 3s, the weakness or paralysis in the limbs, that's obvious. That's the I cannot raise my arm to gravity. So that's a bad thing. Inability to urinate and inability to defecate. I see this all the time. It's harrowing. I just saw this in an 18-year-old kid not a month ago. Inability to urinate, inability to defecate. He was beside himself. So loss of coordination, control of limbs, and shortness of breath. Those are all like, no kidding, tier 3. This is really bad. These are all immediacy of care issues. So this is one of those, you got to get somebody to a chamber, get them on oxygen, get them treatment in some way, shape, or form. So.
Hey, Joe?
Yes, sir.
Question. So theory tells us that AGE or arterial gas embolism, you'll get those symptoms as soon as you surface. When compared to DCS, you can be 5-10 minutes after surfacing. Is that a correct statement? And how long after breaking surface you would expect to have the symptoms of DCS? What's the latest you can have them?
Great question. So here's what we call it, a line in the sand, right? We draw a line in the sand at 10 minutes. And we say from the time that you surfaced for 10 minutes, if a symptom develops in that time frame, you have an arterial gas embolism, right? Now, it doesn't really matter because the symptoms of an arterial gas embolism could be very much any one of these. They could be musculoskeletal pain, rash, lymphatic obstruction, sensory changes, consciousness changes. You could have any of those, right? They may be more central nervous system oriented, but that's numbness, tingling, a hemispherical sort of a droop, an issue like that, right? Any one of the cranial nerves could be affected. I mean, obviously. So, but if it's 10 minutes or sooner, we call it an AGE. If it's after 10 minutes, we call it decompression sickness. Why? We just drew a line in the sand. It really, truly doesn't matter. But both of those are treated in a decompression chamber regardless. And they're treated exactly the same way. Everybody goes to 60 feet on oxygen, and then we wait for 20 minutes and we see what happens.
Right.
We see if the symptoms have significant improvement or adequate response in the first O2 breathing period. If you do, then you can ride out possibly a treatment table 6. If not, with extensions and all kinds of other rules. If not, then maybe you're going deeper and you may need to kind of crush the bubble a little bit or figure out what's going on.
Okay. Thank you.
All right. Yeah, no, great question. Great question. So basically, this is not intended to be a guide for you to select out divers. Basically, if you go in the water and you feel any different when you come out of the water, just because the symptom wasn't on here and might be one of the, less than 1% of the people in the world get it. If you feel any different from when you go in the water till you get out of the water, you should definitely consider that there's a possibility of decompression sickness and you should do something about it, including hydration, right? So I don't want you to be like, hey, that one didn't come up. You definitely want to get to a person smarter than you in hyperbaric medicine and just kind of try and figure it out together, So like I say, I always say this, and it's an old military saying, don't be the senior guy with the secret, right? So the first symptom of decompression sickness truly is deny, right? You deny having decompression sickness, and I know I've had it, right? And I sit back and I go, I'm not bent. I'm fine. I'm okay. I'm fine. I'll be okay. And then before you know it, it's like I am pretty freaking far from fine. So when in doubt, if you think, I'm not really sure if this is decompression sickness, what's the harm in treating somebody? When in doubt, treat somebody. It's called benefiting the diver. That's the way the Navy teaches it. That's the way the civilian community should be doing it. I don't know how they're doing it nowadays, but like I said, and seeking help. You know, there's a bunch of things that could go wrong. I mean, you know, but so you kind of have to do a little bit of differential on it. But generally speaking, if you were diving and you have any one of those symptoms or some kind of a different symptom, you ought to let somebody know. All right. So can I get bent as a free diver? Oh boy. So the answer is yes, you can. It has happened. Whales get bent. Dolphins have been bent. It's one of these like really weird things. As you guys push the limits, you know, it's a stay time thing. And the longer you're staying down there and the more repetitive dives that you do and drops that you do, it can happen. And with COVID, there's that possibility of you having a lung interaction or lung involvement, right? So if you had COVID and you have some possible other problems like a cavitational disorder or some sort of blockage in your alveoli, you could get some sort of an arterial gas embolism because you could rupture that alveoli. Like I said, it is no joke that we have a 30% increase in mediastinal and subcutaneous emphysema. And that's just here in Tampa. I mean, that's just reported from the guys that, you know, that are pulmonologists who see these people on a regular, right? The guy at St. Joe's. I mean, you know, I talked to him and he was floored that he had such an increase. The other things are, we see dehydration has a lot to do with it. There's a paper that came out that said dehydration is not the single largest contributing factor to decompression sickness. And that's probably true, but I think the message was lost on this because don't throw the baby out with the bathwater. Yes, it's not the single largest contributing factor because everybody's looking for a silver bullet. How do I not get bent? Just keep drinking water, you won't get bent. No, that's not true. You can't do that, right? There is no one thing that you're going to do. And that's what everybody was relying upon. So that researcher that wrote that paper was like, look, man, you just can't expect that your silver bullet is going to be liquid. That's not it. But dehydration is bad. It leads to, you know, arterial sludging. It leads to platelet aggregation. You know, there's all kinds of decompression particles that are better served being in a higher liquid environment. If you're dehydrated, it's a bad thing. So dehydration is never a good thing, you know? So, but then he made reference to in the paper that you could get hypervolemia. Yes, it is possible to drink too much water. It's really hard.
Well, in free diving, you will be inducing diuresis a lot. If you drink too much water, it will make you go. It won't. It's not a question.
Yeah.
You know, in free diving, you just go.
Pressure immersion diuresis, right? So then you step out of the water and you get that stand back on the boat and you get that full distribution back down into the femoral artery again. And then what happens? Now you're dehydrated because you urinated away. So it's almost a natural dehydrator, you know?
Quick question for you. Question for you, Joe. So the literature reports that there's some evidence to state that there's higher incidence of neurological DCS in free diving versus scuba diving. And there's a theory of, even if you don't have a PFO to explain arterial gas embolism, you could have increased shunting, AB shunting at the pulmonary level on breath hold because of the vascular changes during blood shift and central hypertension on breath hold. And this is why potentially DCS in freediving is mostly or primarily neurological. Yeah, that's what the literature says. So I want to know what your thoughts on that and why you think that is, and if another theory, I don't know if it's maybe an observation, but in freediving, we always ascend head up.
Right.
100% of the times. I would say 100, but 99.9% of the times, you want to surface going up, head up. So I wonder if the bubbles, because of physics, will go up, right, towards your cranial end rather than not. So what are your thoughts on that?
No, I don't think that I don't think that the bubbles in the head up position would. So what we used to do is we used to treat in the modified Trendelenburg position, right? So what we did is we were left side low, right? Left side low, and then we'd kind of treat for shock with the legs in the air a little bit, right? And we'd strap people to the boards like that. And that's obviously from the position in the heart and the bubble, and then we found that it's just not that important. So now we just treat for shock. We lay in the supine position. Maybe you elevate the legs just a little bit just to make them comfortable, but that's about it. So realistically, I don't know that there's a lot of bubble interaction in the liquid medium that you have inside your body. I mean, yes, there is some, but I doubt that it's a lot. So why do freedivers get more neurological symptoms? Boy, we don't even know why regular scuba divers get it. And there's a lot more scuba divers than there are freedivers. So I could hazard to guess, but we just don't know, man. That's the problem. Yeah, sorry. The unfortunate answer in diving medicine a lot of the times is we just don't know. Because, we don't have a completely diagnostic run of this. Like I said, we don't truly know what causes decompression sickness. We think it has to do with bubbles, but there's obviously an immune system component to it. There's, vascular component to it, So. And the other thing is, by the way, to increase your risk of getting bent is that you guys keep doing those repetitive dives, up, down, up, down, up, down, up, down, right? So people want to know how they can protect themselves. So this is just off the cuff stuff. This is not not a guarantee of protection of any sort, but if you limit your session to about 2 hours, give or take, we find that cold has a lot to do with it, right? Because if you are on gassing when it's warm and then you are off gassing when it's cold, that becomes a problem because you shunt, right? You shunt out of your extremities to protect the core, and you have reduced blood flow when you're cold. So if you start to get cold, your session should end regardless of how long, right? And I mean, realistically, we all know that, even 90-degree water will make you cold after a period of time. If you're in there for 2 hours, that's a long time to be in the water when it's whisking heat away from your body 25 times faster. So you limit those deeper dives to 1 dive a day. I mean, I don't know what the records are. I don't know how deep you guys are going, but the suggestion here from the friends that I spoke to about this was just limit the deep dives to, basically 1 a day. If you're going to try a record, go ahead and just do 1 a day because it's bad. Ascending at a normal speed, obviously, that delta P, that Henry's law, the change in pressure and Henry's law still is in effect. So you are taking on gas. I mean, it is what it is. It's physics. It has to work. So if you ascend at a normal speed, you're better off. Freediving and scuba diving, this is how one of these kids got bent pretty badly. He was freediving and scuba diving and freediving. So he got really badly bent. So don't do that, and don't mix flying after freediving either. You should definitely have a minimum of 12, probably more likely 24 hours of dive time to fly time. Okay. Well rested, stress free. I mean, this all has to do with vasoconstriction. It has to do with the cortisol response. You definitely want to be relaxed. You want to be relaxed for freediving anyway. So the better off you are, the more relaxed you are, the better off you are. Avoid any strenuous exercise. This has to do with perfusion, right? If you're strenuously chasing after a fish, or you're trying to shoot a fish, or whatever it is that you happen to be doing underwater, if you can avoid that strenuous exercise, you decrease the amount of flow. So as you increase the amount of flow, you increase the amount of inert gas delivered to the tissues. So if you keep that flow rate down, you keep that inert gas absorption ability down, right? This is supposed to be a fun sport. If you feel badly, don't dive. Obviously, alcohol is not your friend in this thing. It leads to dehydration. I say stay hydrated because, like Ioanni said, pressure immersion diuresis is a real thing, and you're just going to go. It's simple physics, man. The tank level indicator alarm is going to go high when you get in the water. You get that redistribution of fluid, and you got to go. So, all right. So with that, I'd love to take some questions from you if you have them, or answer any questions you got.
One question, Joe.
Yeah.
What are your thoughts on emergency water recompression in these cases? So in a lot of places where people free dive, it will be remote. There won't be chambers, or evacuation will be somewhat prohibitive. But there will be oxygen tanks, right? 100%, or nitrox. So what are your thoughts on that? Do you think it's advisable if there's nothing else you have, or what do you think?
So we're doing a lecture on this at the World Extreme Medicine Conference in November. So yeah, I did a study on this. I wrote a paper, and it basically it has great efficacy because the solution for decompression sickness has always been, from day one, has always been pressure and oxygen. So those two things in combination. Where you get the pressure and oxygen from, there's a bunch of operational risk management decisions that need to be made. So I'm going to be really silly and say, let's not go back in the water if there's a bunch of sharks in the water, right? Let's not go back in the water if there's a bunch of box jellyfish. Let's not go back in the water if the person has a compromised
mental status.
Right, your mental status is compromised, right? You don't want to put the person at more of a risk. But if you are a walkie-talkie, right? If you are walking and talking, you're oriented to person, place, and time, and you're like, hey, look, I feel cruddy, and you feel like being able to get back in the water. Yeah. Now, once again, that's not professional advice, but would Joe do it? Absolutely. Are there some considerations? Absolutely. What we found is that, you basically will stay underwater until an hour or an hour after symptoms subside. So this was the in-water recompression conference that we had. The thought process is go to 20 feet, breathe pure oxygen at 20 feet for a minimum of 1 hour, or 1 hour after the symptoms subside, no more than 2 hours. So basically you're in the water for no more than 2 hours, and you are doing it for an hour after the symptoms subside, right?
You're talking about air, correct?
No, do not recompress yourself with air.
Right. That's
only recompress yourself with, because the cost benefit analysis is just simply not there.
Correct.
And let's say, even if it is risky, now we are out on the hairy edge, right? I'm talking conjecture. I believe the redistribution of fluid is almost as important as the actual pressure itself. So the oxygen and sitting in the water on the surface would probably be better for you than breathing air underwater. You see what I'm saying? So like, air is not your friend. Air is not your friend. You should not do it. It's never been good. The Navy dive tables still have treatment tables on air. And I tried to get them to take them out I was in for 28 years. I probably tried for 20 of those 28, and they still won't take them out. But yeah.
So in general, then, if someone is in a remote area and they have 100% oxygen tanks, and they have a line and somebody to watch for them on the surface or underwater, and someone is alert, awake, and oriented, times 3, is able to follow commands, is able to hold the line and not sink, then it's potentially, and this is not advice, obviously, right? To anyone. It's just an opinion.
Just an opinion.
Okay,
You
so
should be connected to the line, like
yeah,
clipped into the line. It should be like, because things could happen. You could have a seizure. The other
Mhm.
thing is, if you have a little rubber mouthpiece and a stretchy rubber band that goes around your head, what you want to do is hold that mouthpiece in your mouth. In the unlikely event you have a seizure. If you have a seizure underwater, it's not the seizure that's the problem, right? It's that tonic-clonic, right? It's
the
when
water.
you bite the regulator and spit the reg, then you
Yeah.
try and breathe in water when you come out of it.
Mhm.
The first breath is of water, that's bad, right? So you want to strap that in. This is not a zero risk procedure. There's risk involved, and you need to mitigate those risks. And there's training courses available in that if somebody wants to take them. There's plenty of training courses, and people go through them all the time.
And what is the maximum depth before you get your concern of O2 toxicity? Was is a ATA formula, correct?
In the water, it should be 1.6 partial pressure of oxygen. So basically that is 20 feet on pure O2.
Yeah. So beyond that, the risk of seizures is pretty high.
The risk of seizures is pretty high. It's high enough that it's not worth the cost benefit analysis of, getting back in the water. I mean, because look, if you get back in the water, you got to get out of the water, right? If you don't get out of the water, all bets are off, and it's a short life, so you want to be able to get out. So, do the risk, and like I said, sharks, jellyfish, high, tides, winds, water, sea state, boats, there's so many variables. You just have to make sure that you're not putting somebody in an unsafe situation, Now, if you have a 18-foot pool, a 20-foot pool, a diving well here, yeah, man, sure, that's easy. That's a no-brainer, right? No problems, right? Pretty clear, the water's not murky. There's obviously no sharks, so that kind of thing.
Yeah, I wouldn't
Sharks,
advise. I wouldn't definitely advise anyone to do it, but I would consider if it was myself. Yeah,
it's exactly my thought.
Yeah.
Yeah.
Interesting. We have participants, so any questions? We'll take questions for Dr. Dituri. We have actually a couple of physicians and on the audience now, and this is being recorded. So thank you, Joe.
Yeah, no problem. If anybody's got questions, feel free to ask.
Hey, Biso.
How's it going? I again apologize that I'm in and out here. Today, unfortunately, was more out than in. I'm at work here, like super busy. And you actually, I apologize if I missed you saying that earlier, but my questions about those portable hyperbaric chambers that usually people bring for mountaineering and altitude sickness. Are these at all useful for us? I don't know how much pressure they hold and if that would be enough, but what do you think?
So they go to about 10 feet of seawater, give or take 9, 10, 8, something like that, feet of seawater. If I was stranded on a desert island or a remote place and it was the only thing that I had, I would use that with pure oxygen. That would be easy enough to do. But you cannot fill those with pure O2. You have to just breathe out of an oral nasal mask of some sort, breathe the oxygen, but you cannot fill them with 100% O2. They're not O2 clean, if you understand, you know what I'm saying?
Yeah.
So useful, maybe not. We're talking about the difference between you being paralyzed from the waist down for the rest of your life. If you don't go in it, I'd go in it. Like I said, we're only taking people to 20 feet in the water. So if the in-water recompression says 20 feet in the water on pure O2, and I can get to 10 feet in the chamber, way safer to be at 10 feet in the chamber. But, once again, it's not a complete treatment. It may just stave off the paralytic. It may just, reduce the swelling just a little bit. I mean, once again, we are talking the edge of the lunatic fringe here, right? Because nobody's ever done any studies on it. So.
Okay.
So only 10 feet for the portable ones, or the maximum, correct?
Yep.
That's not much. I mean, that's not much compared to just getting a tank. If it was myself, I would just get a tank and recompress. But
right. If it was me, I'd probably get a tank and go back in the water. But, you know, if I wasn't a walkie-talkie, if I wasn't able to walk around oriented to person, place, and time, you know.
of course, then no way.
Then I
No
would
way.
be like, yeah, sure, I'll get in that chamber before I just lay on land and breathe. You know, so the order of precedence would be lay on land, you know, breathe oxygen, get in the water or get in the chamber, breathe oxygen, and then get in the water and breathe oxygen. You know, I mean, get in the water and breathe oxygen is obviously deeper, obviously better. So.
Gotcha. So, and the deepest you can take patients at your facilities, you said 20 feet?
No, 66 feet in my
66.
facility.
Yeah. So
We can go to 3 atmospheres. Commonly, we treat divers at 60 feet.
Right. Gotcha.
I have another question, and once again, I apologize if we talked about that before. I was just had to be in and out of the call. I hope it doesn't sound dumb, but why oxygen? Like, because I worried a lot about oxygen toxicity in recovery, especially with like barotrauma injuries when I have endothelial lesion in the lung. Do we use oxygen because of the difference, like higher difference, meaning no nitrogen, so we have a faster diffusion of nitrogen? Like, could we use a different gas, like helium, for example? Of course, it'd be super expensive, but would that work?
It's funny. So increasing the off-gassing gradient to 100% is what you really want to do, right? So will that work? What we've seen is that using helium's a smaller molecule. I literally wrote a paper on this too. It's like, oh my God, you just like a softball. So helium's a really small molecule, and it diffuses into tissues about 2.67 times faster than the nitrogen will leave. So there's some isobaric counter diffusion issues going on with helium. If you had, in my opinion, if you had a more similar sized molecule like nitrogen that was of the same speed going in as speed going out, that might be a halfway decent treatment gas. But oxygen is healing, you know, oxygen, you know, it increases the CD34 progenitor stem cell production. It increases your collagen synthesis. It reduces the overall, as a consequence of being a vasoconstrictor itself, it reduces the inflammation. So there's all kinds of goodness that comes from actually using the oxygen. So that's why it's the therapeutic gas of choice. And so the helium wouldn't work, although it has worked in certain cases. You know, it works better if the helium is the actual insult gas, and then you switch to nitrogen to treat. But that's only if you have to go to 165 feet, if you have a real big problem or somebody with a real issue.
Got it. Thank you.
Yeah, no problem. No, it's not a dumb question. That was a great question, man. Like, you think exactly like I think. That was so cool. I was like, I wonder if.
Yeah. Awesome.
Any other questions? Those were softballs.
Oh, wow. You're pulling for softballs.
No, I'm kidding. Come on.
I don't know. In diving, I feel like I don't know what else to ask, but it's so much. I mean, I'm sure I'll probably have a lot of questions. I'm glad you put your information here, because people are going to want to reach out to you. Would you mind sharing your email on the chat function so that everyone can probably ask you questions?
Sure, I could do that, but I don't know that it stays around the chat. So it's Joe at gallantaquatic.com. Now we teach a 40 AMA1 CME course. If you guys are interested, you physicians are interested in getting a certificate of added qualification, we do that here in Tampa, and we go into great detail of what we just talked about. We talk about some of the uses, some of the mechanism of action, you know, and then you can apply it across a broad spectrum of issues, and then maybe deal with some problems better, if you will. But we do that once every other month here, and then once every other month on the road. So, you know.
Amazing. No, yeah, the window's supposed to be recorded as well. I don't have any other questions. I feel like this has been educational. I took your class, I took your course, and I learned a whole lot. I did learn a whole lot of physics.
You're one of those very easy students. You were like, oh, that guy knows a whole hell of a lot about this. Okay.
No, it was great. I was definitely a neophyte on this. So thank you, Joe, so much. And this is
No
will
problem.
be recorded. If anybody has questions, Joe, there you go. That's your, wait a second, chat function. That's your email.
Yep.
And we should be meeting next week for another topic that I'll announce. Thank you so much, Joe. It's been a pleasure having you.
Thank you for shifting your time around to accommodate. I truly appreciate that. You're making people in my life very happy. So thank you.
We'll go dive next time, okay?
Thank you.
Have a blessed day, guys. We'll look forward to talking soon. Bye.
All right. Cheers. Bye-bye.